What up, everyone? How's it going? I'm super pumped up. I have the OG Perio Amigo himself, Dr. Fadi Hasan. And man, if you follow this dude on Instagram, you will see his amazing cases. I'm super jealous. I got two meat hooks for hands, and here I'm working with Mozart. He's super gifted, super talented, straight from Washington, D.C., Dr. Fadi Hasan. How you doing, buddy?
Good. How are you doing, my man? How's
I'm
everything going?
I'm doing good. I'm honestly I'm honored to have you on the show. I've wanted to bring you on for a long time. We've kind of been chatting back and forth, so this is absolutely amazing to have you on here. But I want all of our Bites members to learn about you. So tell us who you are. Tell us what school you go to and or you went to and where you live.
First of all, thank you again so much for the invitation. I know this has been in the books for a while, and I guess we've both been busy. So, first of all, Happy New Year, and Happy New Year to everyone who's also watching. My name is Fadi Hassan. I'm a board certified periodontist. I'm originally from Baghdad, Iraq. To the States in 2008. I did my first dental training back home in Iraq and finished in 2007. Once I moved here, I started studying for my Part 1, Part 2 dental boards and got accepted at the University of Colorado in Denver. So go Buffaloes. After that, I went to VCU in Richmond, Virginia Commonwealth University for my periodontal training and finished in 2015. And I've been practicing in the Northern Virginia and DC for the last 7 years, actually. So it's been a fun ride. It's been a fun joy. And I love DC. I mean, hopefully, if you guys come into DC, please, contact me. And I'd love to meet everyone whenever possible.
Man, that first I gotta back that up here. So you were a dentist in Iraq first.
hmm Yes.
What
So
is
I finished in
dentistry like in
2007.
Iraq? What is that like?
Well, I'm gonna be honest with you. I mean, Nikki. So for me, I did my dental school. My first year of dental school was in 2002, 2003, when the war started. So I mean, it wasn't the most pleasant experience.
Yeah.
You talk about bomb explosions and people getting killed right and left, and you go to the school. You see a lot of, you see bodies on the street. In other words, just the best way to describe it. And you see all these incidents happening in front of you, people close to you. Sometimes stuff happens to your. I mean, something happens to you directly. I've shared my experience with what's happened to me personally when I was in Iraq, and what I went through, and all the incidents that happened to me as well in the past. So again, not the most fun experience, but I think
Yeah.
definitely makes you have a thicker skin by the time you graduate and you leave. So, as far from an educational point of view, I think at my time when I was there, it was really hard. We lost a lot of our faculty in the process, from assassination attempts and all the
What?
religious, sectarian violence, the religious aspect of it. So, I mean, by the time I got to my senior year, we were barely doing, clinical dentistry. So for me coming to the States, it was really my opportunity to actually learn dentistry because I had so much love and passion for it by the time, I graduated from dental school, even though it wasn't my first choice. I
Yeah.
always wanted to be a medical doctor. So getting to dentistry when I was 18, it's like, damn, I don't want to be a dentist. That was my
Yeah,
first
yeah.
impression. I loved it, and I found I have a great talent with carving teeth. So became one of the clinical instructors at the time, with dental anatomy in my first year dental school. And I continued until my graduation. So I got into it, and I loved it ever since. And Again, moving to the States, just a whole new experience. Studying for the dental boards, and you had no clue what material to look out for and what material to study.
Yeah.
So luckily enough, Colorado was the first school I applied to, and the first school I got accepted into. So I was very young when I started, the international dental program in the States,
Yeah.
um, and um, and after that, I got into Perio, and luckily, I mean, the funny thing is actually not luckily, but funny thing is that Perio was one of my worst subjects in dental school, and I was always getting C's, and it's like, man, this is a tough subject. So I started like just shadowing the Perio residents, and I was like, you guys need to explain to me Perio because I'm really terrible at it.
Yeah.
And the more I started shadowing, it was like, man, this is really cool and fun. Like, I want to do this. So, doing a couple of externships in dental school, and the irony is I became a periodontalist myself. So there you
Yeah.
go.
Man, I actually failed my competency in perio. And when I was in dental school, I thought periodontists just did scaling and root planing all day. And I was like,
Yeah,
man, that's what they teach us. Like we don't know that they're doing these crazy, connective tissue graft, the Zucchelli technique. Dimitri's teaching me all this stuff. And I'm like,
exactly.
this is what a periodontist does. Like, why didn't anyone tell me that? But
Yeah,
man, I
exactly. I mean, yeah, yeah, we have no idea. Like I said, it's all about that's what they teach you then as a dental student is like general scaling and root planing, and then you hang out with the grad paras, and it's like, holy moly, those guys are doing some crazy rigid augmentations and sinuses and immediate implants and provisionals and all the soft tissue works. Like, well, this is different. This is not
yeah,
para that
no
I
one
know.
told me
I
about
want to
that.
do
Yeah.
this. This is cool.
So how like what made you jump into perio then? Like you did some externships, but how did you
Yeah,
decide on perio?
so
It doesn't sound like you did any GP at all. You went straight into perio.
For me, the reason I went to Perio is actually one of our faculty in Colorado, and he started a kind of non-credited class after school hours. It's like, hey, if who's interested in Perio, just come and join. We're gonna just discuss some cases with the residents. And what he did actually did an amazing job. And every day for entire summer semester, I would go after school, and we never had breaks in Colorado. I don't know why. They only give us like 2 weeks a whole year, just that way how the school program was. So during the summer semester, I was going after class from let's say 5 to 8, and he would bring a local periodontist in the area where they would come in, they would show their cases, and that's how I got into it. So we started like 25 students. By the time and it went for a full year, we would show up literally every day, and then became like once a week. Once I got into more school, and we started getting a little busy with the clinics, and went for a whole year like this. And we started 25 students. I think we end up like being maybe five, and those
Yeah.
five are the ones that all went to perio residency.
Oh, really?
We were the last. I was like each one of us. I applied to perio residencies. We all got in
Yeah.
from our school, and so he's the one actually really pushed me, Dr. Michael Cantor, and he's like one of the big names in the world of perio, and he was one of our faculty at BC at Colorado University. So I did an internship at University of Maryland, and then BCU, and I decided to go with VCU because it was just tuition free. It's like that's a no brainer. I'm definitely going to VCU,
Yeah.
and some great IV experience, like IV sedation
Right.
experience, and that's what I really was interested in. So when I graduated, and luckily, I brought the IV sedation into the practice, and I do a lot of IV sedations, and it's been a huge practice builder for me. So that was one of the reasons why I actually chose that school specifically.
Yeah, I have to agree with you there. I do a ton of IV sedation myself, and I
Yeah,
feel if you took that away from my practice, I would look for another profession. I find I can't practice
exactly.
without it. And
Me too. Like
yeah, and I
I
think
feel
it's funny
100%.
because I get so many people ask me like, Nekky, should I do IV sedation? And I'm like, yeah, for
Mhm.
sure. And they're like, but Nekky costs $30,000. And I'm like, who cares? It
It's
like
worth
that
it.
that initial $30,000 is worth your entire career. Like when you spread it out, it is the best thing you'll ever do. You agree?
It's a best return of investment when you do
Yeah,
IV sedations. And honestly, I mean, if you think about it, whether you charge $500 to $1,000, I mean, you're talking about 30 sedations. You already paid the tuition fee for it.
totally.
So
Yeah,
your question, you're definitely doing more than 30 cases a year.
yeah,
To be honest, so you make your money back within maybe 3 months if you want to do 10 cases a month, even if you
yeah,
just think about it that way. So I think the return of investment with IV sedation is great, and it's I think it's much safer for you and for
absolutely.
the patient.
Yeah,
I don't do a lot of oral sedations. My
no,
associates do a lot of oral sedations, and I,
yeah,
I personally don't like it because I don't control it. I
that's
can
right.
control IV sedation. I know how much to give them and how much I need to reverse. So
Yeah.
for me, it's a much safer environment. It's a calmer like scenery itself. So I like that part of it as well.
Man, I totally agree. I think oral can be reckless because people, they'll give zero point 0.5 milligrams triazolam and then they'll add hydroxyzine. And I'm like, you have no idea at what effect you're letting this kick in. You can't titrate this stuff. And
You
it ends
can
up,
titrate it.
no, no. So,
It's I
no,
think it's just more. I think I do believe it's more dangerous with oral because everybody metabolizes very differently, and
Yeah.
you don't know when it's going to hit them hard. And it's like, oh shit, now they're all of a sudden not breathing really well, or you're like very respiratory depression. So I was like, okay, now I have to start doing the reversal agents. And now do I start an IV, or I mean, you have to start an IV eventually for it, so to
Don't.
reverse them. So yeah, so I think just IV is a safer method. Yeah, that's how I see it.
Totally, totally. Speaking of IV, I find I was really well. I got into venipuncture by doing PRF first, and that allowed me to get
Oh,
better at get or more comfortable at doing IVs. Do you do PRF in your practice?
I do. So actually, when my research and residency was all about PRF,
Really?
and I used my own blood
Yeah,
to actually use it as samples for the PRF because it was all like in labs. So when I was defending my thesis, I was like, and these samples are from me. So
yeah,
my sweat and blood went into that thesis.
yeah,
So
yeah.
there is just laughing about it. But I did a lot of PRF, and I still do honestly, not as maybe as much as extensively as before, but when it comes to bigger ridge augmentation cases, I do see the wound healing of it is just unbelievable. Decreased amount of pain because we did see in the studies that there is the level of pain does diminish significantly when PRF is utilized because of all the growth factors that come with it. So
Absolutely.
definitely expedites wound healing process, and that's what I love about it, honestly.
Yeah, no, I couldn't agree more. I've been doing PRF for almost a decade now, and I'm teaching it on this Friday. So I'm excited to fly back out to
I love
Vancouver,
it.
see my homies, eat some
Yes.
Korean food. It's gonna be awesome. I wish Dimitri was coming. Every time we all get together and eat Korean food, we always give a little prayer for Dimitri because when he,
I swear he can speak Korean,
yeah,
Dimitri.
he is
I tell
Korean
you
now.
that he is. I think he's Russian and Korean. There's a soul, a Korean soul inside him, 100%, because he knows all the food. He knows
Yeah.
what to order, every single thing. He knows the culture more than anyone else.
Yeah, no, no, no. I hear you. And that's how I found out about you. Dimitri was like, man, you got to meet my boy Fadi. And I'm like, yeah, man, for sure, for sure. And when I first I looked you up on Instagram, I was blown away by your passion for Perio. Just watching one of your Instagram lives. If anyone's interested, your Perio handle is, or sorry, your Instagram handle is.
Mine is
Yeah,
fkh.implant.perio, and usually I'm the one who starts the Instagram live. So all the previous Instagram the IG lives is on my feed actually. So you guys, if ever want to watch it, it's all cases that we are day to day. So we share our successes and our failures, and that's the fun thing about it. It's like we can do beautiful stuff, but this is our screw ups, and this is how we handle our screw ups. We're proud of it. We get to
yeah.
learn from it.
And I find that impressive because when I scroll through Instagram, I never see failures. I only see these beautiful cases that I know my meat hooks will never be able to obtain. And here you are, you're proud to show your failures, but you show your successes. And man, you have phenomenal cases. And I was blown away by your passion for perio. So I was always interested, like, what gets you excited? Like on a day to day basis, what procedures excite you? What do you look forward to?
For me, I have a lot of passion for soft tissue and soft tissue surgeries. It's delicate, it's finesse, it's art. The way we suture things, how things kind of sit back to each other. And when I do it, just like it's my zen, in other
Yeah.
words, and using the 7-0 sutures and the 6-0 sutures. So I recently been doing more 7-0 sutures. They're way finer. They're way more gentle. So you have to be extra careful with the soft tissue, the way you manipulate it, the way you stabilize it. So it's just for me, it's like when you have the instruments and the needles, it's like you're doing it's like a small symphony, in other words, and you're just gently doing it, and that excites me significantly. Funny thing, 5 years ago, it was all about full arch cases, and that one thing used to get me excited more than anything else. But the last few years, it's switched off, and I do find just a lot more. It's less headaches with soft tissue, in my opinion. I just enjoy more, less headaches, and the results just they're very rewarding because you can see them within a short period of time. So that's kind of been my go-to thing recently, whether it's natural teeth or soft tissue grafting around implants, which are a little bit more naturally more challenging and more complicated. But just getting those results at the end is very, for me, it's very satisfying, and also for the patient as well.
Yeah. And I hear your passion, man. Like, man, it's a symphony. I love that. I love that, man. But tell me,
Yeah, it's just
7O sutures. First of all, A, how do you see them? And B, like what magnification? Are you using a microscope or do you just got like 10 times the
no,
loops or
I
what are you
use a
using?
three. I use a three magnification. Sometimes I might jump to a four. So recently I broke my four magnification, so I have to go back to a three, and that's when I actually start using my 7.0. So finally, I repaired my 4.0 sutures. So my 4.0 magnification. So now I get
Yeah.
to enjoy my 7.0s a lot more. But it's really all about the needle holder, like the
Really?
what to buy, which one to buy, because there are needle holders that are really meant for anywhere from 6.0s to 10.0 sutures. So there are really nice ones. I think it's Lachelle.
Lachelle, yeah.
If
Yeah.
those ones, the what's called the I can't forget that. I forget the name of it. The one that is like a non-twisting one. It doesn't actually, the suture doesn't hook onto it. Those ones are phenomenal for 7.0 sutures. Like you can hold it very carefully, precisely, and tie them on. It does not break the suture. So I've been very pleased with that company when it comes to using the 7.0 sutures with it.
Really? I have a pair of Lachelle, but I
You
didn't know I should be using them for 7.0.
they have fine pointy tips, and you can literally grab the tip of the needle and also the tip of that suture and gently and tighten, and does not break on you. So it's a very meant for microsurgeries. That one, I love it.
Man,
It's
it's
one of my favorite ones out there.
man, I'm still stuck in the realm of free gingival grafts, and I'm proud of free gingival grafts, and my connective tissue skills aren't nearly even a 1%
You need
of
to
your
come.
ability.
Yeah,
I need to go.
you need to come, dude. You need to come.
I'm definitely coming. But the whole point of this show is to kind of get people that don't graft very much, or they're
Mhm.
nervous of grafting. Because man, as a GP, I was intimidated by going to the palate and carving a little tiny piece of sashimi underneath the the gums just to try to get a little piece to suture to another spot.
Yeah.
It's intimidating. Where does the GP start?
I think if you want to like start with soft tissue grafting, I think the best things, and definitely, the free gingival graft is your bread and butter. It's the most resilient type of graft, and it's a test of time. So I think that's a great place to start. Is with your autogenous tissue. Don't
Yeah.
go, don't go like donor skin, because it is way more technique sensitive and has a higher risk of infection if you don't understand how to manipulate the tissue. With soft tissue, it's amazing. Like, we have a lot of attendees when they take our course. They've taken a lot of bone grafting courses before that,
Yeah.
and when we start showing them the soft tissue, and they're switching from using 3.0, maybe 4.0 sutures for closure, now they're switching to 5.0s and 6.0 sutures. They do see like it's much harder for us to suture. It's like it's a very different procedure by itself. So um, and the best way to start is again with the free gingival grafts. The best site is usually the forefront teeth, because
Yeah,
those
man.
ones are needed the most. I think when it comes to free gingival grafts, and as you progress and you feel more comfortable with the free gingival grafts, then you slowly transition to the root coverage procedures. So again, there's many different techniques. I think between me and Dimitri, we show close to about 4 to 5 different surgical techniques for root coverage, because there's just so many out there. Um, and again, they all have their purposes. They all have their indications and contraindications, when to use them, when not to use them. But the beauty about FGGs, free gingival grafts, is there's pretty much only one technique to do it. So there's no other tricks or ways out. It's just one way, and that's the way that gets you really the nice, most predictable results. So understanding biology, understanding how to do your partial dissection, how to prepare the bed, the harvest of the graft, and the layers, the thickness of the harvest also matters. So taking that into consideration, and you can see some really nice predictable outcomes in whether it's a natural tooth you want to graft, or for your full arch cases of the mandible. So it's all about choosing the cases for it.
Totally. And I couldn't agree more. I am feeling super comfortable doing free gingival grafts on the lower anteriors because you're right. Those are the sites that need it, easily visible. But I still remember the first time I went to the palate, man, it just started gushing and it was gushing blood and it scared
Yeah.
me. Give us some tips. The first timer going to the palate, we're all a little jittery and then this thing
Okay.
starts pouring. What are we doing here, man?
The best thing, honestly, for you guys, if you guys are doing frictional grafts and there's a bleeder, first of all, try not to go too far posterior and
Right?
don't go too close to the midline because that's where your greater palatine is. If it bleeds, make sure you always have a 3-0 suture. And that's the
Oh,
only time I get to use 3-0s because what I do is I bite a nice kind of a deep horizontal bite that goes from the gingival margin of the tooth almost close down to the midline of the palate, and a very deep bite, and I cinch it hard, and that really helps stop the bleeding.
really?
Yeah,
Wow.
that's a
I
trick.
didn't know that. Okay. Okay.
There's
So
absolutely that's
suture,
the
deep
magic
suture.
trick of stopping 90% of the bleeding. Just cinch it
What?
hard with a 3-0 suture.
Here
That's
I
it.
thought I'm just like, I get my assistant like, okay, put some wet gauze on here and just push. I'm going to go grab a coffee. I'll be right back.
No, just make it literally like just go in deep and just it's going to look like a circle. So I just tie it hard, and what happens is, especially distal to your harvest.
Right.
That's the key thing. You have to go distill your harvest and get a very deep bite. Make sure you reach down to the periosteum and then come out closer to the mid palatine,
Yeah.
and then cinch it really hard, 2 to 3 knots. And it's amazing how you see it will automatically just like you will decrease the bleeding by close to like 50 to 60%, even sometimes 100% in most
Really.
cases. And that's try it, and you'll see the results. That's what we've
See,
been doing for the last 10 years now. We've been doing soft tissue.
and do you leave that in when the patient leaves? Or is that just while you're
Yeah,
there?
it's a resorbable 3
Yeah.
chroma gut. Let it stay there because if you remove it, it's going to start bleeding again. For me, when it comes to the roof of the mouth, I love using some collagen plugs or collagen tape.
Yeah.
I will do some crisscross sutures also with 3-0 because I think 3-0 is the best for the roof of the mouth.
Right.
Sometimes I might use a 5-0 glycolon because it's a strong suture. It's also absorbable.
Yeah.
And I will use that. And I love using periacryl, which is
Tissue
adhesive,
glue.
soft tissue
Yeah.
adhesive, and exactly tissue glue. And the recent research actually has shown that using periacryl with a collagen sponge gives you the least amount of morbidity for the patient as well, the most amount of comfort. So that's another thing that just came out as a new research and publication recently.
Really, I love that because
Mhm.
I always use pericryl over the sites whenever I've tried to put something over it, like a colla tape or Surgicel or something like that. I find it falls off. Did you
So
ever
the
have those
way
issues?
it happens if you don't put a suture like a crisscross suture on top of the collagen plug because the
Right.
collagen plug helps absorb it
Yeah.
and just kind of stabilizes the blood clot within it. And then I will put a wet gauze and I put some pressure on it for maybe 2 to 3 minutes. Once I do that, it's nice and flat, and then I'll get the periacryl and I'll just dab it, get some Vaseline, we'll swipe it with your finger, and it immediately makes the periacryl nice and hard, and it just kind of solidifies it, and that's it. There's no more bleeding. So my
Vaseline.
harvest to suturing, it does not take me more than maybe 5 to 7 minutes from harvest to suture to completely done, and then I'll start working on my recipient side.
I don't know about the people watching, but this episode has been amazing already because that is the best tip. First of all, distal suture, 3-0, just kind of stop the bleeding, collar plug,
It's really
pericryl,
comfortable. Yeah,
Vaseline over, and uh,
that's it.
and and that does it.
The swipe of your finger, and it immediately stabilizes everything, and that's it. And patients don't swallow the periacryl. Sometimes it goes back to their throat. When you use the Vaseline, it actually kind of stops them in the right place. So it's
That's
a
awesome.
really comfortable way of doing it.
Do you ever use a palatal stent? Like some people will make an Essex that goes over the palate.
So great question. That really depends on. I don't do one personally. It really depends on my referrals. Some referrals, I will ask them, "Can you please make me a palatal stent?" Some of them will make them for me. Some of them don't. I would say out of the every 100 cases, I might get 2 palatal stents.
Okay, okay. But
So
I find
I
that
like
your technique is good.
tomorrow I have a free gingival graft. Yeah, tomorrow I have a free gingival graft for the first time in a long time. The dentist is actually making me a palatal stent because I requested it. I was like, "Can you please make me a palatal stent?" It's like, "Yeah, sure. We do it
Yeah.
all the time." It's like, "Thank you. I appreciate it." they're making me one. It's like I'm going to enjoy my gum graft tomorrow because there's going to be less bleeding than I use a
No,
painful stem.
that's cool. That's awesome. Okay, so you harvest your tissue. When you want to take it to the donor site, do you just put it on a glass slab and maybe put saline on it? Or how do you prepare that
Great
graft?
question. Make sure it's in a cold saline bath. When you have your
Oh,
harvest, if you're yes, make sure it's a cold saline bath. I have a dapping dish, like a sterile metal dapping dish, sterile saline, and I like to bring it from the fridge so it's nice and cold, and that way it helps it's kind of like cryotherapy. In other words, like it's literally keeping the cells alive a little bit longer. So there's a hot environment, so cold saline from the fridge, and that way it maintains the longevity of the graft, so it doesn't shrink more, and also it doesn't die on you quickly. So I've been doing that a lot recently, and once the bed is prepared, I'll just simply take it out. I do have a sterile, a tongue depressor, a
yeah.
wooden tongue depressor. I love using that one, and I will just cut it, trim it on it based on how I like to see it. And then I always irrigate in that process of the trimming, so it stays nice and well irrigated and hydrated. And once it's done, I'll just take it to the site and I'll start suturing. I always start with the corners. I'm sorry, actually, sorry. I used to start with the corners. Now I start with the midline. So
Oh,
if I want my graft in that position, start in the midline, make your first knot there, and then do the corners. Because if you do the corners first, what happens is that it will pull it to one side, and the other side looks short. So start in the midline, and then gently pull the corners. It sits perfectly where it wants to be sitting. So that's another trick.
I'm laughing because I just did that today. I did the corners and I'm like, man, this graft sucks.
I used to do the corners so much. I was like, God damn it, man, why is it so short? Like, I know I harvest a long graph. And
Yeah,
then I learned actually from my good buddies, and he's like, hey, try midline. And he's more experienced, like, okay. And I trust, like, huh, that actually
yeah.
is a much better outcome. I like the midline.
I
It
like the
works way
midline.
better.
Okay, I'll try that. I'll try that. But tell me, what happens if you get your
Yes.
graft from the palate and then you take it to the recipient site and you're like, crap, it's too small.
Good question. So for me, I like to always go I always harvest bigger than I always want to.
Yeah,
So kind of rule of thumb, go bigger because you can always trim it. If you go smaller, no one wants to go to the palate again. They're already going to suffer from the discomfort of the free gingival graft. An extra 2 millimeters is not going to kill anyone. It's not going to kill the patient, but it's going to be more comfortable for you as the surgeon doing it. So now, let's say you did harvest and it is smaller. What I like to do, I like to do the accordion style FGG. So I'll make my FGG and
yeah.
I'll do like small cuts and it looks an accordion and I can easily stretch it out.
Oh, okay, okay.
So
So there
I
are
do
little
like that
tips.
technique and it works awesome. Like for example, I have cases where I'm doing a free gingival graft from premolar to premolar. Well, there's so much you can harvest from one side of the graft, from one side of the palate. I personally don't like harvesting from both sides because it's so uncomfortable. I like
Yeah,
to give them one side to chew on. So what I'll do is I'm the person that I will go from back from the tuberosity and I will continue one graft all the way to the midline. So it's 45 millimeters, sometimes a 5 centimeter long graft if I think I need to do it that way. But if it's still not enough because you want to stretch it, I'll do small accordion cuts and actually I can extend it another maybe 4 or 5 millimeters if I think I can do that. So I've done it multiple times and it works really well. But you have to make sure your graft has to be a little bit wider to do the accordion technique
right.
because if you do it too thin, it will slough off and you don't have enough blood supply to the graft itself.
Fair enough. No, I hear that. I have another question though, because I see your cases, I see Dimitri's cases, and a lot of other awesome periodontists.
Mhm.
Why are you guys using multiple different kinds of sutures on like a free gingival graft in like the lower anteriors? I see sometimes they're using PTFE, chromic gut, proline, the purple glycagon sutures. Like why are you
But
guys why are you guys using so many different types?
I think it just depends on your preference. For me, when it comes to free digital graphs, I'll either use. I think when I first started, that they teach you to use Chroma Gut because simply it's the cheapest product in the market.
Yeah,
I know periodontists that will use Silk, who like the old school period, like the ones who are 70, 80 years old who are still practicing.
yeah,
They only use Silk, and I mean, I would never use Silk in today's day and age. For me, I love using monofilament. So my go-to has been 5-O glycolon and 6-O glycolons. Those are my go-to. I don't like using polypropylene, the non-resorbable one, because it when especially with regional grafts, the graft gets sometimes thick and tends to grow on top of the knot.
Yeah,
And
yeah.
getting and cutting that is really uncomfortable for the patient. I know Dimitri loves using 6 O's for regional grafts, and kudos to him. Personally, myself, I love using 5-O glycolons. It's resorbable. I don't have to remove them even at 4 weeks later. Just dissolves themselves, and they're really comfortable for the patient. Their tensile strength is really strong for the first 2 to 3 weeks. So I mean, almost acts as a non-resorbable suture, which is perfect for me. So that's been my go-to when it comes to using suture materials. And if you look at all my cases, it's either 5-O or 6-O glycolon, and the 6-Os are clear, so you
Yeah.
can barely see them.
And the 7 O's are even worse, I'm guessing, hey?
I've never used 7-Os for FGGs. I don't think I ever will, because I'll be really torturing myself to remove those sutures.
Yeah.
I've been using 7-Os for strictly for root coverage procedures and for additive tissue regeneration, like if I'm doing modified mist techniques for my interior cases. So I have a couple of nice posts. They'll be coming soon on Instagram. I got them already, like for 7-O, and you'll see how tiny those sutures are when comparing to a 6-O.
Yeah. No, I can't wait to see it. I'm a huge follow. I don't go on Instagram much, but I follow the dentists that I admire, and you're definitely one of them. Um, on your Instagram
Thanks, man.
lives, you share successes and you share failures. Um,
Mhm.
and I feel like you do that because you have a passion for teaching us. When you and Dimitri created Perio Amigos, what was your guys' goal? And like how do you guys approach teaching us GPs differently than maybe some other institutes out there?
So for me, just to give you I'm actually a faculty at BCU. So I'm a one of the assistant clinical professors. So I've been teaching for the last since 2016, a year after I graduated. So I love the concept of teaching. When me and Dimitri got into Instagram, and we were talking so much about soft tissue, and we just kind of threw in the idea. It's like, hey, do you want to do a live IG together? I was like, sure, we'll discuss cases. And this was during COVID. So we got in, and it was a lot of fun. And we did another one. And then it was like, hey, dude, we've done like three now. What do you like? I think we did two at that time. It's like, what do you think about doing a soft tissue course together? It's like, since you have passion and I have passion, I love teaching, and we both like share cases on Instagram. And our live IGs have been also really fun. People have been engaging it really well. So
Yeah.
why don't we give it a shot? So that's how we came up with the Perio Amigos, and none of us are amigos. Believe me, I'm very Iraqi, he's Russian, so I'm not sure how that name even came into the play. It
Yeah.
just came in, and for some reason it worked. Um, so we did the Paramigos, and we started. I mean, we've done two soft tissue graft courses already in Philadelphia, and they were a really great success. So, and we keep learning from each other, because that was our first time even seeing each other. It was in Philadelphia for our first course. Never
Really?
met the guy
What?
personally, one to one. It was the first time. So I think, and we had our instruments were not there. They got lost in the shipping. So it was with so we were really stressed out. Like, oh my god, our first was going to be a disaster. We
Yeah,
have no
yeah.
surgical instruments, and we last second we were able to scramble here and there to make it happen. So, but the second one was much better, because we got into the rhythm of being simultaneously together on the same stage, and then bouncing back and forth. So it got way more fun and interesting. And we also improving our slides, as we kind of went through it. So our third one is going to be next month in LA. So we're doing one in the West Coast, because a lot of friends have been asking, hey, please come to the West Coast, do one there for us. So we're doing one in LA next month, and March, end of the month. So all the information is on our Instagram posts, and also on our bio. And simply just go to perioamigos.com, and you'll see the entire description of the course, what we teach, hopefully. So it's 2 days, hands-on, big jaws, and lecture. And also take our I take these out for dinner and drinks the first night just to make sure we kind of socialize with them, get to know them better. So we make it fun and engaging, and really just joke around and make it as fun as possible. That's the whole thing. And we teach them the hands-on portion, which is really crucial. Just showing them how he does his soft tissue and how I do my techniques, and the outcomes of it at the end of the day. So it's fun because he does things very differently than I do when it comes to soft tissue, and that's what makes it a lot more fun and interesting, I think.
Totally. And like, I've seen your posts. I know Dimitri, he does a ton of Vista, for
He does
root
it.
coverage. And yeah, do you do Vista as well?
I do a lot of this stuff. He does it way more than I do. So I have actually I have few cases that's again I've been really collecting my cases. So I was looking at my phone. I have close to maybe about 5 to 7 cases that are ready to be posted. Like and
Yeah.
between Vista, Volcodontics, immediacies, all the different GTR. So they're you guys are gonna see them soon. Like Vista from like 19 to 30, all
Wow.
soft tissue grafting. So like major grafting and using donor skin. So I have a few of those cases that are ready to be posted as well. Um, but I mean, I would say most of my cases are open flap or tunnel for me. And if it's a single site, I love using vertical incisions. I think those work really good in my hands. Dimitri, he loves Vista, and he has that technique really nailed down, and he knows how to manipulate the tissue in a really beautiful way, and how he stabilizes the graft, how he takes that bite and stabilizes in the right dimension. So I mean, and I've learned a lot from him. I mean, when I have a case, I'll discuss with him, hey dude, I think I want to do this Vista. How would you approach this? Where would you stabilize it? So we go back and forth, discussing cases and kind of approaching it. So it's been a really fun journey, and he has an amazing experience. I know, so it's been educational for me as well, just kind of doing it with him too.
Man, I've been telling you. I told Dimitri, as soon as I can travel again, I'm vaccinated, but I'm trying to get COVID so I can get the positive PCR test. So I got 90 days free immunity to travel back and forth, and I'm going to Hawaii and Vegas and Perio Amigos in Philly or LA.
Dude,
I'm there, man.
everyone's getting it. It's a matter of time until I get it. So I'm just waiting my turn
Yeah.
at this point in time.
Hey, so for a GP starting out in root coverage,
Yes.
I think you said it already, but would you recommend their first root coverage case? How do you make it easy? Where can someone jump in? Are you recommending like vertical incisions and so you can see everything, open flap, or are you recommending something like Vista? Where do you start?
I really think it depends what you're comfortable with and what courses you take,
Okay.
and what techniques they're showing you. And I'm going to give you a very simple example. When I did my first soft tissue course, I took one after residency, and I took the tunneling technique, the Pat Allen course, and because I didn't get that much exposure back in residency, so I learned it from him himself. Went to Dallas, Texas, learned it from him really nicely, and I really applied that, for my later on experience. I think as time went by, and it's interesting, you learn a technique, sometimes you just stick with that technique because you get really good at it for a period of time. And then you start seeing some cases that I don't think I feel comfortable using this technique on that specific case. So that's where you start, seeing if there's more courses out there that can help educate you and maybe can expand your knowledge. So um, I wouldn't say like one technique is better than the other. I can never say that because each technique has its pros and cons. What I love to do again, and this is what me and Dimitri do, is that again we show you how to do a vertical releasing incision approach, how to do an envelope style approach, a Vista approach, a modified Vista approach, a tunneling technique. So there's 5 techniques that you get to actually experience all in those 2 days, and pick the one that you are going to feel more comfortable with. You've learned them, try using them. We kind of give you a decision tree as far as which areas to use which technique. Because, for example, I rarely use Vista for maxillary posterior. I like to either tunnel it or open flap it. That's just me personally. Canines, for me, I love doing vertical incision on canines because
Yeah.
I get to get so much release and I get so much more coverage. That's just me personally. Mandibular anterior, it's usually between using it. Most of the time, I'm doing a vista because it's a really easier approach for me for mandibular anteriors to do vista. So again, it just depends on your, understanding the anatomy, how much vestibule you have, how much keratinized tissue you have. That all comes into play choosing the right technique for you. So, you know, I'm never going to tell you one technique is more superior than the rest because that's BS
Yeah.
in my profession. Anyone who tells you that, that means they're biased towards teaching you their only one and only approach. So I like to expand the knowledge that learn them all, pick the one that you're comfortable with, play to your strengths and your weaknesses, and see which one you're more comfortable with.
Yeah. No, no, no. I hear exactly what you're saying. I respect that. But what about around implants? Like when I first
Uh,
started doing locators, I
yes,
found I was throwing these locators in. I'm a champ. These guys got dentures that snap on. They're, the like button snaps, like, a typical
yeah,
locator. People are happy. But, 5 years later, I'm looking back at my cases. There's no keratinized tissue. I maybe have bone loss to the second or third thread now. I'm a little disappointed. I wish I paid more attention to the soft tissue, but now I am. And now I
okay.
want to go back and graft these cases. Like a lot of GPs
Mhm.
out there, where do I start?
I mean, FGGs, I mean, that's your using autogenous tissue. That is your bread and butter. I mean,
Yeah.
that's the best place to start it. And it's one of those things that you can do them and get a nice thick harvest, a nice piece of thick sashimi, lay it down there, stabilize it well, and it will last you hopefully for a lifetime. Don't get me wrong, they still shrink
Right.
over time. Even 5, 10 years later, you might see some shrinkage. Some cases, it depends on how much bone reduction you've done. If you've done very minimal bone reduction, they tend to stay a lot longer and much wider. It's when we start being a little bit more aggressive with our bone reduction, especially for our full arch cases,
Yeah.
where we're going to the basal bone, there's only mucosa. When you do a pharyngeal graft there, most of the time they're going to shrink very aggressively
Mm-hmm.
because no, remember, our attached gingiva is meant to stay on alveolar bone, not as much as closer to the basal bone. That's where the mucosa and the muscle attachments are genetically meant to be stabilized there. So I've done a lot of cases where, for overdentures or even full arch cases on the mandible, where I was more aggressive to get that nice bone width so I can place my implants, and I did my FGGs, and amazingly, they still shrink because I know it's
Yeah.
like, well, yeah, I removed half of my alveolar bone and down to basal bone. So guess what? That's not where keratinized tissue is meant to be. It's meant to be attached on alveolar bone where your natural dentition was in the past. So that's something I think it's really important, for us to understand when talking about locators, how much bone reduction, where to place them. And people are starting doing FGGs. Well, why did they shrink? Well, how much bone did you have? Where
Yeah.
did you start with placing your implants? So that comes into consideration.
Until you just said that, I don't think I've ever, fully comprehended that, but maybe indirectly I did. You're totally right. Free gingival grafts or keratinized tissue isn't meant to sit against basal bone. And that's where we see the muscle attachments, and that's where all the alveolar mucosa is. So, just by genetics, it's a difficult
Yeah.
situation right from the bat. Wow, that's smart. But now that I know better, and now that a lot of us know better, we try to do better. Um, if you have an edentulous case, and
Yes.
you want to do 2 or 4 locators, there's like a
Mhm.
millimeter of attached tissue. Are you grafting, like, are you soft tissue grafting first before you place the implants, or are you doing it after?
Oh, I love that question. It depends what your baseline is. So if I have more than for locators, let's say if I have more than an approximate anywhere 7 to 10 millimeters of just beautiful wide keratinized tissue, most likely I'm not grafting.
No.
It's the cases that have about 5 millimeters or less. Those are the ones 100% sure. And then when I'm grafting it, I'm usually grafting it. I mean, I'll say it just depends on what your goal is. If you place the implant, you can graft it simultaneously, or you can graft it prior to. I think if you graft it prior to, you can actually see how much shrinkage you're going to anticipate, which is
Yeah.
not a bad thing, and then you can kind of split that difference in half when you're going to place your implant. let's say you start with about 7 millimeters, and after the surgery, now it's shrunk down to, let's say, maybe about 4 to 5, then you can do it after. So it really depends what you end up with, or what's your starting point and what's your end point. If you have a lot of width, no need. If you feel like I'm going to do it, I'm going to split it, I'm placing my locator, but I know it's going to shrink, then you can do it maybe later on. If you're already starting with such minimal amount, then start at the beginning. Just be safe, have a
Yeah.
lot of KT, so that we can split it in half comfortably, half to the lingual, half to the facial, and that way you are in a good, comfortable zone, nothing to worry about it as well. So that's just a very small, I think, breaking it down from a decision tree point of view.
Yeah. No, I totally hear what you're saying. If you do it before you place the implants, like, you're recommending
Mhm.
if you don't have very much tissue to begin with, what about the denture? Like they've been wearing this denture for 20 years or, even 5 years. Um, you've just placed your free gingival graft. Are you telling them not to wear the denture for like a month, or are you letting them, like, if
Yeah,
you relieve the
for
denture?
me, honestly, if so, great question. If they are, if let's say if they have, no, do they have implants or they don't have implants at that point
No
in time?
implants
That's a
yet. No implants yet.
no implants yet. I tell them if they are wearing the denture, I'm going to relieve the entire facial aspect. I'm going to cut that thing off.
Yeah.
I'm just going to keep the tooth, and there's absolutely no vestibule. I don't want anything touching my graft because
Right.
that's going to be anything in my mobilize it, might displace it, and that's going to cause the graft to fail. So it's like anything else. You do a bone grafting surgery. Do you want your patient to wear a flipper on it and just put all that pressure on it?
Heck no. No.
No. What we're
No.
doing, either taking it into an Essex, or we're literally shaving the entire buccal vestibule away because we want absolutely no pressure on that site. So how's it so different from a soft tissue graft?
Yeah.
That's the key thing. If they're wearing a maxillary denture, it's great because that's going to protect. That's like a palatal stent, in
Right.
other words. I love it when they do that. But when it
Yeah.
comes to mandible, and for an overdenture case, I will definitely cut away the buccal vestibule, and I might keep, for example, the posterior vestibule. At least they have some better kind of stability of
Some
the
support. Yeah.
prosthesis itself. But I will definitely relieve the facial. Um, because I'm assuming most of the time they're going to have a new prosthesis when the new denture is set in and the new implants are set in. Most of the time they're going to get a new prosthesis. It's going to be much better fitting with a newer and a deeper vestibule. That's another important factor because
Yeah.
you are going to do your GG. You're going to lower your vestibule. So guess what? It's going to be a deeper one. So you have to make a new prosthesis to accommodate for the new depth of that vestibule as well.
Man, I love it. I could literally talk to you all day because I have questions for miles because I've been in all these scenarios where I've messed up, and I love this, man. I cannot wait to go to Perio Amigos and I'll bore you guys with all my questions. But at the end of the day, I see my fair share of failures, and I'm not hesitant to share them because this is life and this is dentistry. Sometimes we see red flag patients right off the bat. You in your consult, you're like, man, this is just going to be a nightmare right from the start. What are some red flags from a soft tissue grafting point of view that you automatically spot that you're nervous of before you even start a case, and what would you recommend us GPs to just stay away from?
Oh, I would say lingual recession is on my red flags because every time I see lingual recession, I feel like my heart drops. And I literally might lose. I lose a year of my age
Okay, okay.
because they're the hardest. They're the hardest is the lingual ones. That's a red flag for me. I think one of the hardest ones for GPs when they start doing soft tissue therapy is going to be your mandibular interior post ortho
Post ortho.
because post ortho. Here's why.
Why?
And I show when we do our course, I show the participants all the post ortho cases that I get to treat.
Yeah.
And they're not usually 1 or 2 years later, usually 5 to 10 years after when their patients are 25 to 30. Most of my soft tissue cases are young patients, they're 25 to 30 years old, most of them. And I get to see them, and I see the roots are almost sticking out of the gum, screaming for help. I was like, there's like I can literally poke it with my finger and I can touch the bone. That's how thin and frail that
Right.
tissue is.
Yeah.
So my recommendation for those cases where you can see almost like the waviness, you can see the prominence of those roots. Be very careful with those ones, I think those are red flags. They definitely need a little bit more experience on how to manage that tissue because it's almost non-existent. In other words, it's
Yeah.
all attached mucosa, very little amount of keratinized tissue in most of those cases. The canines are scary, bulging out. So the question remains: well, how is the size? What's the length of the graft that I'm using, and what's my incision design going to be? So just be careful with those ones because when you start, never tunnel it and never vista it because you will tear the heck out of it trying to just elevate that tissue from those concavities.
Yeah.
My safest approach for those cases is going to be an open flap, like a completely envelope style. I can gently reflect it and I can slowly push the tissue away. I can place my graft and I can advance it again. So that's the safest approach, I think, in my hands when it comes to those post ortho cases. Yeah, so that's one of the ones I look at as like, oh boy, this is going to be a hard one. I keep scratching my head, and then I get there. So should I do an FGG? Should I do a root cover? Should I just thicken the tissue? Should I do an open flap? Should I do like a Vista approach? And I might go through my head like 3-4 times. When I know the patient's like, yep, I'm doing this one now, and I just within a moment was like, this is the technique I'm doing for you. So it's gonna make it happen. So there's a lot of last minute decisions when those post ortho cases, and it's you'll. I think once you start numbing that tissue and you start seeing how much vestibule you have, it's a really good like factor to know what approach you're going with because then you have a real understanding about tissue manipulation once that tissue is nice and known.
Yeah. Wow,
Yeah.
man. I don't think I've ever considered post ortho being that much of a concern, but now that you say that, they've pushed the roots so far forward. That bone is paper thin as well as the tissue. So you're 100% right.
As
I
well as
see
the
that.
tissue. Yeah, I think for me that's my scariest one. And again, areas with severe crowding. So if there's
Oh
thin
yeah.
tissue, but there's just so severe crowding, because I know those ones like I will never be able to pass my needle through, no matter how small my needle is.
Yeah.
So a lot of those times I will have them go to ortho, knowing the fact that they already have thin tissue, they have recession. So I will send them to ortho just to kind of just gently correct that crowding. And I will tell the ortho, once you do that, please stop, just pause it. Let me do my soft tissue graft. 2 months later, continue. And they
Yeah.
only need 2 months of good healing, and they can continue. And you have now a thick, healthy, thicker phenotype, nice root coverage, and they can continue with their ortho, and they can knock their socks out with ortho after that. It doesn't
Yeah.
bother me anymore. It doesn't.
That's a really good point. I should talk to my orthodontist about that. I love it, man. I've learned so much already, and it's only been 45 minutes. Man, thank you so much for coming on the show. We all greatly appreciate it. I genuinely greatly appreciate it. I've learned so much. I cannot wait to meet up with Dimitri and my new homie Fadi, and we are gonna go for some old fashions, and I'm gonna
Oh
attend a
yes. Oh
Perio
yeah.
Amigos course for sure. Thank you so much. And
Thank you.
any last words for us, my friend?
No, just again, thank you for the
Yeah.
opportunity, and hopefully we'll have a chance to meet you guys soon. Hopefully at one of our courses, it'll be a true pleasure and honor. And again, we don't hold anything back. We try to show you whatever we do. Honestly, with a lot of passion because we love soft tissue so much, and and we make it fun and enjoyable. So you get to guys to ask us, and it's a good educational course. So. Hopefully, we get to see you soon, Nikki. And thank you again for the wonderful invitation. And I'm sorry the share screen didn't work, as I had so
Nah.
many good cases lined up for you and for the audience. But hopefully, I'll have a chance to show it to you guys sometime later.
No, it's awesome, man. So we'll see you on Instagram for sure, and we'll see you on your Instagram lives. Your Instagram handle again is one more fkh
It's
dot
implant.perio.
fkh.implant.perio. Fadi,
Yep.
thank you so much. It was an absolute honor, and
Thank
we
you.
will see you guys next week. Have a great day, guys.
All right. You too, man. Take care.